Welcome guys to the pediatric revision part 5. In this we will see the neurological disorders, respiratory disorders and cardiovascular disorders in the babies. First neurological disorders, इसमें हम देखेंगे न्यूरल ट्यूब डिफेक्ट्स. इन न्यूरल ट्यूब डिफेक्ट्स क्या क्या टाइप्स होंगे उसके वो देखते हैं. एंड रिस्क फैक्टर्स फॉर द न्यूरल ट्यूब डिफेक्ट्स आर इन्फेंट ऑफ डायबिटिक मदर. अगर इन्फेंट जो है डायबिटिक मदर है, डायबिटीज़, then folate deficiency is important cause. Then drugs consumption by mother, that is valproate and phenytoin. This can cause neural tube defects. Neural tube defect can be cranial or the caudal. Most common type is caudal one, in which spina bifida. In cranial one there can be anencephaly and anencephaly. So neural tube defects caused by location are anencephaly and anencephaly. In cranial end and in caudal end there can be spina bifida, which is most common one. Then craniorashes and encephalocele can be seen. Then next one, as we saw, the folate deficiency can cause neural tube defect. So we need to give folic acid. To mother. What will be the dose? 400 microgram. अगर previous history है, with previous history of neural tube defect, तो child born with neural tube defect, then mother को कितना देंगे? 4000. Then 4000 microgram of folic acid is spina bifida. Then UHG can detect this neural tube defect by 14 to 16 week. And the markers in amniotic fluid can be acetylcholinesterase and alpha fetoprotein. Right? There are different types of neural tube defects, and the folic acid should be started 1 month before the conception, or periconceptional folic acid supplementation should be given. Folic acid preconceptionally can be given. 1 month before folic acid should be started, and dose is 400 microgram. If previous history is there, 4000 microgram. Then next topic is hydrocephalus. In hydrocephalus, normal CSF pathway. We'll see normal CSF pathway. CSF is produced from choroid plexus of ventricles. From the choroid plexus, CSF will form, and CSF flows from this lateral ventricle to the third ventricle, then towards fourth ventricle in the pons, and from this fourth ventricle there are foramens, that is foramen lusca on the lateral side and foramen magentae on the medial side. This will drain in subarachnoid space. And remaining CSF will flow down toward the central canal around the spinal cord. This regulation is going on. अगर CSF प्रोडक्शन ज़्यादा हो गया या फिर ये फोरामेंस जो है वो ब्लॉक हो गए, then there can be increase in CSF that will cause swelling, or this type of swelling in the baby's head. This is known as hydrocephalus, right? Hydrocephalus is of two types: non-communicating and communicating. In non-communicating, it can be due to the obstruction. And most commonly it is due to aqueductal stenosis. Other causes can be Dandy-Walker syndrome, Arnold-Chiari malformation type 2, and vein of Galen malformation. In communicating type, there is no any obstruction. Then why CSF is increasing? It is due to increased production, either increased production or decreased absorption. Increased production due to that choroid plexus choroid plexus papilloma, that is tumor of these cells, will cause increased production or decrease absorption. Decrease of absorption due to the pus which is formed in meningitis, mostly bacterial meningitis. Investigation of choice for hydrocephalus is MRI of brain. In management, we need to shift this excess CSF to the other parts of the body. That is, we will form shunt, and most common shunt is ventriculoperitoneal shunt. That is VP shunt. Most commonly used is VP shunt. These are normal lateral ventricles. Around this, the choroid plexus is there. This choroid plexus will form CSF, and that will flow around these ventricles or into these ventricles. Okay. There is non-obstructive hydrocephalus due to choroid plexus papilloma or bacterial meningitis. Then this abnormal swelling of ventricles, increase CSF, that is hydrocephalus in MRI of brain, and this image is showing ventriculoperitoneal shunt. Next one is seizures. There are different type of seizure, but most common cause of seizure in children is febrile seizure due to fever onset. It should be within the 24 hours of fever onset. 24 hours के अंदर होना चाहिए जब fever आएगा. And it usually occur in the children of 6 months to 5 years. 6 months to 5 years is febrile seizure. Seizure should be within 24 hours of onset of fever, and there should not be any infection. Or any meningitis symptoms like increased ICP or neck stiffness should not be there, and febrile seizures are seen in developmentally normal children. So management can be, we can give PCM for fever control, and for seizure control we can give benzodiazepine like midazolam, diazepam or lorazepam. Then prophylaxis can be given in this febrile seizure children till the age of 5 years. Febrile seizure occur till the age of 5 years if they are recurrent and first episode is below 18 months children, and family history of seizure is present, and if it is recurrent, that is more than equal to 3 episodes in last 6 months अगर है, then we can give prophylaxis. For prophylaxis, this is also known as intermittent prophylaxis. First 3 days of जो fever होंगे, first 3 days of fever में ये prophylaxis दिया जाएगा. Okay. In simple febrile seizure, there is no risk of epilepsy. Is seen. No risk of epilepsy in the future. Simple are known as typical febrile seizure, and complex one as atypical febrile seizure. This is the tonic phase of the seizure. All muscles are in contraction, and this clonic phase. This is the clonic phase. Tonic and clonic phase. Mainly in febrile seizure there is generalized tonic-clonic seizure. In simple febrile seizure there is GTCS of short duration, less than 15 minutes is seen, and it should be within 24 hours of fever. And complex seizure, also known as atypical febrile seizure. Then next one is this scenario of this child, something staring and unawareness is there in the class. It is school going children, mainly 5 to 15 years. This seizure is seen in 5 to 15 years. There is no postictal confusion. On EEG there is 3 Hz spikes are seen. Then this unawareness, 5 to 15 years and school going children, Then diagnosis is absence seizure. Absence seizure. 3 Hertz spike and wave pattern is seen, and no postictal phenomena. And drug choice is sodium valproate. Now next scenario is adolescent, and this myoclonus on awakening in the morning. सुबह सुबह जब उठेगा तब गिर जाएगा. That adolescent and conscious during the episode. This is early in the morning. And the child will conscious during the episode, and on EEG, this 4 to 6 spikes in wave pattern is seen. Then this is myoclonic seizure or juvenile myoclonic seizure. Juvenile myoclonic epilepsy, and is also known as Jan's syndrome, seen mainly in adolescent. And treatment is sodium valproate. Next one is, there is an infant less than 1 year child, and there is spasm of neck flexors. On EEG there is hips arrhythmias, like this. Hips arrhythmias are seen on the EEG. These are hips arrhythmias are seen. These are hips arrhythmias on EEG. This is diagnosis is infantile spasm. Less than 1 year child is an infant, and neck flexors are goes in spasm. This is infantile spasm. Types can be cryptogenic variety or symptomatic variety. That idiopathic or cryptogenic is better prognosis, and symptomatic one is a poor prognosis because underlying brain lesion is there. And the treatment for infantile spasm is ACTH. This is important question. ACTH, adrenocorticotropic hormone. If this is associated with tuberous sclerosis, then treatment will be vigabatrin. These are hips arrhythmias on EEG, right? So हमने 3 देखे EEG patterns. 3 Hertz, 4 to 6 Hertz, and hips arrhythmias. 3 Hertz, this is absence seizure. Then 4 to 5 Hertz seen in adolescent, that is juvenile myoclonic epilepsy. Then hips arrhythmias seen in infantile spasm. Treatment is, drug of choice is ACTH. Important question. Drug of choice is ACTH. The next one is syndrome is Lennox-Gastaut syndrome. There is 2 to 12 year children. में दिखाई देता है. और characteristic triad of low IQ, that is intellectual disability. Then it is associated with multiple seizures, and EEG finding 1 to 2 Hertz. So 1 to 2 Hertz seen in Lennox-Gastaut syndrome. Lennox-Gastaut syndrome. 2 to 12 year children. This is developmental delay or low IQ. Other seizure we saw, उसमें developmentally normal child था. Lennox-Gastaut में low IQ है. low IQ. Then next one is, this is central sulcus of the brain. अगर central sulcus कहीं पे mention है, then that is Rolandic epilepsy. ये एक benign type of epilepsy है, जिसमें child gets older. Child जैसे जैसे बड़ा होगा, child get older, and this epilepsy settle down. Epilepsy will settle down. Is also known as benign epilepsy of centrotemporal spikes. These are focal in nature. Focal seizures are there. And treatment is carbamazepine or oxcarbamazepine. oxcarbamazepine. Then next one is status epilepticus. These are prolonged seizures. Prolonged seizure, tonic-clonic in the nature. You can differentiate in between. We can say time 1 and time 2. Time 1 and time 2. Time 1 is according to when the treatment is started. If it is within 5 minutes treatment is started, then time 1. And time 2 is the persistence of this seizure. If it is more than 30 minutes, then we can say it is a poor prognosis. FMG के लिए इतना इम्पोर्टेंट नहीं है. Okay. Then treatment क्या देंगे for status epilepticus? That is benzodiazepine, lorazepam, then phenytoin, and then valproate. Phenytoin की जगह phosphenotoin भी दे सकते हैं to prevent the thrombophlebitis. To prevent thrombophlebitis, we can give phosphenotoin. Thrombophlebitis is inflammation of veins. Now next one is, these are meninges. This skull, dura mater, arachnoid mater, and pia mater. In meningitis, these meninges are affected, and this meningeal irritation will give symptoms like neck stiffness, neck rigidity is there, increased ICP, intracranial pressure is there, right? Then fever associated with seizures and signs of meningeal irritation are seen. Fever plus seizures and signs of meningeal irritations are seen in meningitis. There are two main signs are seen: Kernig sign and Brudzinski sign. In Kernig sign, we flex thighs and knees of the baby. We flex thighs and knees and slowly extend it, and pain is felt by the child. If he is having meningitis. Next one is Brudzinski sign. Passively flexion of the neck of the patient causes flexion of the leg also. Causes flexion of the leg. On passive flexion of the neck, there is flexion of legs seen if meningitis is there. Investigation by CSF analysis. There is increase in proteins, increase in pressures in the cases of meningitis. If viral meningitis, glucose is normal. If bacterial meningitis, glucose is decreased. Bacteria loves glucose, so glucose decrease in bacterial or tubercular, and glucose is normal in fungal and viral infection. Lymphocytes are increased in viral infection, viral meningitis, right? And bacterial and tubercular, there is increased protein and pressure, there is decreased glucose. So how we can differentiate? In bacterial, there is CSF turbid in color. अगर CSF turbid है with this glucose decrease, then it is bacterial meningitis. Then it is tubercular meningitis. If the CSF is turbid, then it is tubercular meningitis. Turbid is tubercular meningitis. And complication of meningitis can be seen: seizure, subdural effusion, or sensorineural hearing loss. For sensorineural hearing loss in children, we do Bera investigation during the discharge and follow-up. We do Bera investigation during the follow-up and discharge. Next topic is management of this meningitis. For bacterial meningitis, we can give third generation cephalosporins plus aminoglycosides. And dexa can be given. The steroid dexamethasone can be given to decrease the inflammatory edema. It decreases inflammatory edema and decreases the risk of sensorineural hearing loss. So we give third generation cephalosporin with aminoglycosides and dexa. The next one is respiratory disorders. In respiratory disorders, first topic is pneumonia or respiratory disorders are आगे है वो. और the most common cause in bacterial meningitis में most common cause है streptococcus pneumonia. जब inhale किया जाएगा nasopharynx से, then it will reach the brain meninges, and treatment we have saw third generation cephalosporin plus aminoglycosides, and dexa is given to decrease the inflammatory edema. E. coli is the second most common bacterial cause of neonatal meningitis, and first one is GBS, group B streptococcus. Most common cause is neonate. Most common viral cause is Japanese B encephalitis, which is caused by this Culex mosquito. Okay,